pieces that you're going to need. Pressure bag. Bag of normal saline. Bridget, got that? Careful, it's open. You have your iPod holder right here. Holds your transducer. All right. And you have your actual line. This is your CVP monitoring line. This is a special line that's in our supply room, right? That connects directly to our central venous catheter. Keep in mind, also make sure we document our central venous catheters. Doctors don't always document their central lines. So I don't
And
have
that's
a
under
central line
LDA.
LDA. So make sure you go into
CVP.
LDA and type in CVC, central venous catheter, and then you'll have the options: single, double lumen, triple lumen. Just go ahead and pick your triple lumen central venous catheter. So this is the piece that you're going to have here. This is everything. This is everything. You're here. You're going to look at. Let's take a look at this and see the components of this. This part right here, nothing abnormal about it. It just looks like normal primary tubing, right? Once we get to this part right here, this is your transducer. This is the way to take your your physiological signal from the body and turn it into an electrical signal that's going to be monitored by your MP50 monitor. All right? So that's your transducer. You have some stopcocks right here. You have a stopcock, you have a yellow cap. Keep in mind, when it comes out of the package, it comes with a white cap. All right? The yellow cap comes in an additional bag that you're going to go ahead and screw this off and put it back on. And lastly, here's the remaining part of the line. This is your syringe. When connected to your central line, you could drop blood directly from this syringe without having to unscrew or remove ports and clean up the ports. Just go ahead, draw it up directly from here. All right? And lastly, I didn't bring the central line, but the central line was the most integral piece to this as well.
Where'd it go?
I thought I had it. Oh, you know
you're
where it
talking about
was?
the ports, with the distal port, with the brown.
It
and
was
the...
on the last bed that we had here. That was over there.
Oh, shoot.
No, that's all right. No worries.
Okay.
All right. So what Bridget's going to demonstrate is how to go ahead and set this up. So first of all, it's just the beginning part of it is priming it just like normal saline, like you're priming a regular bag of saline. All right. So nothing special about that. All right. Good. Let's go ahead and hang it up right over there. All right, so what we're doing here is we're setting all this up while the doctor is putting in their central line. So doctor's putting in their central line. We're going to set this whole setup. All right. So what you're going to do is now you'll notice the roller clamp is open. You're not seeing any dripping right here. All right. So what you're going to do is squeeze right here. You'll see these clamps right here. All right, these wings. And when you squeeze there, that's going to prime the rest of the line. All right.
I remember,
So
was
go
it
ahead.
300 or 500 was supposed to prime to, or something?
Just go ahead and all you're doing right now is priming out all the bubbles in here, all the air in here. So until you start seeing it drip. All right. So you can see it dripping right there. You can see it dripping right over there in the drip chamber. All right. So that's how we know. Make sure we also have all these little bubbles out here. Yeah, you'll see a whole bunch of bubbles in here. Make sure those are all primed out. Right? Now the cause of these micro bubbles here, it's because usually that happens when you prime this under pressure, right? Which is probably what we did earlier to speed things up. But when you prime under pressure, you're gonna have all these little bubbles. Thing is, what happens is all these micro bubbles here all add up and can alter your CVP reading. All right. So that's all right. We're good. All right. So at this point right now, what you're going to do next...
Can I just say something?
Yes.
So you want to set it up without the pressure bag
Without
first,
the pressure
then?
bag. Correct.
Okay, got it.
Without, no pressure. All right? So next, you're going to go ahead and take your bag and pressurize it to 300. All right? So while Bridget's doing that, there you go. I'm going to set up this iPod holder right here.
Do you want to put it on it?
Right. Here you go, Vanessa. This is our transducer holder. Now, if you guys remember from the old days, well, I know some of you guys remember what we used to do is we took a towel, rolled up a towel, and taped this transducer up in the towel, and then just shoved it in their armpit. All right. Where this is supposed to be is it's going to be lined up with the phlebistatic axis. Right. This is basically your fourth intercostal. All right. The reason why is, well, it's this coincides pretty much almost identically with your fourth intercostal. At that level, that's also where your central line is going to be located, at the superior vena cava. Right? So this pretty much measures up alongside, in line with the distal end of your central line. Make sense? This with the central line. All right? So we're pumped up to 300 yet? Almost there? All right. We're getting there.
We can just
Warmed
pretend.
out here. So one more thing, while Bridget's doing that, is I'm going to go ahead and on the left side or the right side of the just go ahead, or Vanessa's going to do this. She's going to go ahead and put this on right here. There's a little hole right inside there. All right. Nope, and then put it right in there. And then just, okay. So if you look, it should line up phlebistatic axis, mid-axillary line, fourth intercostal, right there in line with your superior, with the distal end of your central line. All right? All right, all set, Bridget? So here we go. This end will go to your distal port, all right, which is in a triple lumen catheter. It is the brown port, the distal port. It's labeled on the line, but it's the brown port. So this will go in the brown port, all right. Now the final piece here is a series of removing caps, twisting this stopcock, and zeroing it out. We're zeroing it out to the atmospheric pressure, all right. So here, I'm going to show you this. Bridget, come on over. Go ahead and press. Go ahead and start it on, turn it on. There we go. Now, this piece right here is your CVP cord. It looks like a phone cord. If you take a look at it, it looks just like your phone jack, all right? Where that's going to connect, you got it. You're already holding it right there. Go ahead and connect it. And you'll see, without even pressing any other buttons on the monitor, you'll see what happens. Just instantly, you'll see the CVP line just pop up, all right? So without even pressing anything, CVP should pop up. Can you guys see that? All right. So with this, now we're all set. We have that primed up to, we have the line primed, bag is pumped up to 300, the transducer at the phlebistatic axis, and this connect, and the distal end, and this connected to the distal end. All right. So at this point, patient no higher than a 30-degree angle, if possible, no higher than 30-degree angle. And what you're going to do here is you're going to go ahead and turn this off towards the patient. So turn the stopcock off towards the patient. So towards the patient is this end right here, right? So turn this, wherever this arm is off. So turn it off towards the patient. There we go. All right, so it's off towards the patient. Next, you're going to remove the yellow cap. Remember, it comes packaged with a white cap, right? You can squeeze out a little air bubble in there. Go ahead. There's a little air bubble. Good. Lastly, with this open to atmospheric pressure, go ahead and press the CVP line itself. You'll see 0 CVP. All right, 0 CVP. You'll know it's zeroed when you see a 0 right there. And you'll also see at the bottom, last 0 at November 2nd, 16:39 p.m. All right? So that's how we know we're zeroed now. At this point, go ahead and put the yellow cap back on. Turn the stopcock off to the yellow cap. And now you are measuring your central venous pressure. All right? Now, keep in mind, central venous pressure, what that is the amount of back pressure being placed at the distal end of that at the distal end of that central line. All right. So what you're measuring is how much back pressure is being placed at that end. So normal CVP, once again, for you and I and everyone in this room, is what is it, Vanessa?
2 to 6.
2 to 6. Any one of us. Now we know, once again, sepsis is a form of distributive shock where the blood is in the body. It's just not distributed evenly, right? We have blood pooling in the extremities, so the blood's there. Our job is to get blood to the heart, all right? So that's why in sepsis, what's the first thing we do? If we take a look, and our CVP is 2 or 1 or 0, the first action that we're going to do is bolus them, right? So we want as much fluid right here in the heart to get more oomph out of that heart, right? So normal, 2 to 6. Septic patient, it might be around 2 to 6. It might be 1. It might be 0. It might be even negative numbers, all right? The reason why the goal that we want is 8 to 12, okay? Because we want to make sure that perfusion's not an issue. We want to make sure that blood is getting to the heart. And making sure, all right, that's one piece of it, one component of this whole puzzle. Blood is at the heart, fluid is at the heart, all right, so we can pump it out. So that's why we want it 8 to 12. Second piece is MAP, all right, MAP. What is MAP?
Mean arterial pressure.
Arterial pressure. What the importance of MAP? We want a MAP of greater than 65, all right, greater than 65, because what MAP is, the importance of MAP is how much it's basically how much blood, how much oxygenated blood your end organs are seeing. So your liver, your kidneys, your end organs. If that map drops below 65, we're not getting enough perfusion to our end organs. Therefore, once you have more organs starting to go hypoxic at that point, it'll ultimately lead to multi-organ dysfunction syndrome, which increases your mortality rate. So that's why we want our MAP greater than 65. And the drug of choice to get MAP up to 65 is norepi, levofed. Excellent. All right. It's predominantly an alpha drug. When high dosages that we're using, greater than 10 mics per kilo per min, is predominantly used for its alpha purposes. What is alpha? Once again, it shunts blood from your periphery to the core, to the heart. All right, so that's what we're doing with levofed, getting blood right here, squeezing blood from your big toe to right here, right? And ultimately, getting more oomph out of that heart.
So it's vasoconstrictor.
Yep, it's a compressor, it's a constrictor. And the last piece is SCVO2. So I'm going to show you that last piece right there. So SCVO2, oh, I didn't bring my central line. We could pause it right here. I'll go get a central line because that'll demonstrate the last piece of this where we're going to